So here is the question. The intraoral radiograph presented in the color image is suggestive of which of following? So it is suggestive of globulomaxillary cyst. So it is a cyst that has been described as fissurable cyst that is found within the bone between the maxillary lateral incisors and the canine. So in this radiograph, you can see a cyst that is present between the maxillary lateral incisor. This one is the maxillary lateral incisor and it is the canine. So it is radiographically what you would see is it is a well-defined radiolucency that frequently cause the root of adjacent teeth to diverge. According to WHO, you have to remember that this is the cyst that is classified under a debatable origin. So it is found within the bone at the junction of globular portion of the medial nasal process and the maxillary process. Other name of globulomaxillary cyst is premaxilla maxillary cyst. So premaxilla maxillary cyst is it is a globulomaxillary cyst. Features: it's it seldom ever presents clinical manifestation. So it can be discovered during the routine radiographic examination. On radiograph, you will see an inverted pear-shaped radiolucency. It is a pear-shaped in appearance. Pear-shaped radiolucency that is present between the root of lateral incisors and cuspid. So that will cause divergence of the root of the adjacent teeth. So the treatment, it should be surgical remove and preserve the adjacent teeth if possible. This 16-year-old boy has a sparse hair and complained of heat tolerance. What is your diagnosis? So in this pic, the clearly answer is ectodermal dysplasia. So what is ectodermal dysplasia? It is manifestation of which that could be due to the one of more ectodermal derivative. The tissues that are involved in ectodermal dysplasia, the defects are in skin, hair, nails, salivary glands and the teeth. What you see is the dental, hair and nail anomalies that are evident during the infancy or the childhood. The number of hair follicles, sweat glands and sebaceous glands, there is a reduction in the hair follicles from sparse scalp hair to a complete absence of hairs. The sweat glands, they are absent. The mouth may be dry from the hypoplasia of the salivary glands. The lacrimal glands may also be deficient. The nails are brittle and thin and show abnormal ridging. So there will be anodontia or oligodontia, that is the complete or partial absence of teeth that will be affected in the both deciduous and the permanent dentition. The alveolar process does not develop in the absence of teeth. The salivary glands are sometimes hypoplastic in nature that results in xerostomia. So there is no treatment for this condition. With the anodontia, we can give denture as early as possible to the patient. Identify the image as shown in the diagram. So this is a hairy tongue that is characterized by accumulation of keratin on the filiform papilla of the dorsal tongue that results in hair-like appearance. So what you will see in the hairy tongue is there will be increase in the keratin production or decrease in the normal keratin desquamation. Hairy tongue most commonly affect the midline just anterior to the circumvallate papillae, sparing the lateral and the anterior borders. The elongated papilla are usually brown, yellow, or black as result of pigmentation producing bacteria. So there will be elongated filiform papilla that may be elevated. So the diagnosis is usually made from the clinical appearance. What you will see in the histopathic examination, you will see hairy tongue that is characterized by marked elongated and hyperkeratosis of the filiform papilla. It is generally a benign condition, so it has no serious sequelae. The major concern is often aesthetic appearance of the tongue with the bad breath. So if you do periodic scraping or brushing with the toothbrush or tongue scraper, it will promote the desquamation of hyperkeratotic papilla and surface debris. Remember, you should avoid any confusion of hairy tongue with hairy leukoplakia that occurs on the lateral border of tongue. Hairy leukoplakia is caused by which virus? It is the Epstein-Barr virus and is usually associated with HIV infections. Herford syndrome is characterized by a triad of, the answer is B, uveal tract inflammation, parotid swelling, and facial paralysis. Herford syndrome is a form of sarcoid that occurs in the presence or absence of systemic sarcoidosis. It is characterized by enlargement of the parotid gland, facial nerve paralysis, and anterior uveitis. What is uveitis? Uveitis is the inflammation of the eye. The mucoepidermoid carcinoma has been classified based on all these features except yes. The answer is degree of invasion in adjacent structure. The traditionally mucoepidermoid carcinoma has been categorized into one of three histopath grades. Number 1 is the amount of cyst formation, second degree of cytologic atypia, and third relative number of mucous epidermoid and intermediate cells. So, the low grade tumors show prominent cyst formation, minimal cellular atypia, and high proportion of mucous cell, whereas the high grade tumor consists of both squamous and intermediate cells that can demonstrate pleomorphism and mitotic activity, whereas the intermediate grade tumor show features that fall between low and high grade. The cyst formation occurs, but it is less prominent than observed in low grade tumors. Now let us discuss few more points about mucoepidermoid carcinoma. As the name implies, the tumor is composed of both mucus secreting and epidermoid type cells. Columnar and clear cells are also seen. Which of following is the most common site of occurrence? For the mucoepidermoid carcinoma, it's the parotid gland. Intraorally, you will see a strong prediction for the palate. Generally, a female prediction. It is the most common malignant salivary gland tumor in the children. Which is the most malignant salivary gland tumor in the children? It's the mucoepidermoid carcinoma. On histopath, what would you see is the mucus secreting cells as well as epidermoid type and intermediate cells. The mucous cells are of various shape and have abundant and pale and foamy cytoplasm. The epidermoid will have squamous feature that demonstrate a polygonal shape intercellular bridges, and rarely keratinization. The most common site for the thyroglossal cyst is, first of all, thyroglossal duct cyst is a neck mass or lump that develops from the cells and tissue remaining after the formation of thyroid gland during embryonic development. Where are the thyroglossal duct cysts located? In an entrance exam, you will get a question like this and identify this image, this cyst. So the answer will be thyroglossal cyst. First of all, this cyst is located in the midline of the neck. That you have to remember. The thyroglossal cyst is present in the midline of the neck, and it accounts for almost 70% of all the congenital neck anomalies. It is commonly seen in the preschool age children and during mid-adolescence. Now, what is the site of thyroglossal cyst? The most common site of the thyroglossal cyst is below the level of hyoid. So your answer will be 1. So this is hyoid, and the most common site will be infrahyoid. So they are located in the midline, tucked next to the thyroid cartilage. Now, how can you diagnose this? You can diagnose by the history collection or physical examination. On the physical examination, what you would see is the mass. This mass will move upward when the tongue is extended and with the swelling. So when you swallow, this mass will move with the tongue when the tongue is extended. As the thyroglossal duct cyst is often connected at the base of the tongue. Other investigation you can perform is the blood test, ultrasound examination to create an image of blood vessels, tissue and organs to evaluate the mass and surrounding tissue, or you can do thyroid scan to reveal any physical abnormality of the thyroid, or FNAC may be done. So what is the treatment? The treatment is the surgical procedure to excise the thyroglossal cyst. The operation is known as cyst trunk procedure, and it is performed under general anesthesia. So what you do is you make a small incision over the cyst. The cyst and the entire tract are removed, as well as the midline portion of the hyoid bone. So it is important that the cyst and attached tract all are completely removed. If some portion is left behind, there are the chances that cyst will reoccur. And the tissue that is removed will be sent to the pathology lab to confirm your diagnosis. The most common site for the thyroglossal cyst is, first of all, thyroglossal duct cyst is a neck mass or lump that develops from the cells and tissue remaining after the formation of thyroid gland during embryonic development. Where are the thyroglossal duct cysts located? In an entrance exam, you will get a question like this and identify this image, this cyst. So the answer will be thyroglossal cyst. First of all, this cyst is located in the midline of the neck. That you have to remember. The thyroglossal cyst is present in the midline of the neck, and it accounts for almost 70% of all the congenital neck anomalies. It is commonly seen in the preschool age children and during mid-adolescence. Now, what is the site of thyroglossal cyst? The most common site of the thyroglossal cyst is below the level of hyoid. So your answer will be 1. So this is hyoid, and the most common site will be infrahyoid. So they are located in the midline, tucked next to the thyroid cartilage. Now, how can you diagnose this? You can diagnose by the history collection or physical examination. On the physical examination, what you would see is the mass. This mass will move upward when the tongue is extended and with the swelling. So when you swallow, this mass will move with the tongue when the tongue is extended. As the thyroglossal duct cyst is often connected at the base of the tongue. Other investigation you can perform is the blood test, ultrasound examination to create an image of blood vessels, tissue and organs to evaluate the mass and surrounding tissue, or you can do thyroid scan to reveal any physical abnormality of the thyroid, or FNAC may be done. So what is the treatment? The treatment is the surgical procedure to excise the thyroglossal cyst. The operation is known as cyst trunk procedure and it is performed under general anesthesia. So what you do is you make a small incision over the cyst. The cyst and the entire tract are removed, as well as the midline portion of the hyoid bone. So it is important that the cyst and attached tract all are completely removed. If some portion is left behind, there are the chances that cyst will reoccur. And the tissue that is removed will be sent to the pathology lab to confirm your diagnosis. So this image will represent the bifid uvula. What is bifid uvula? It is a uvula that is split or forked. It is also known as cleft uvula. A uvula is a dangling piece of fibrous flesh you can see in the back of your mouth, just in the front of the tonsil. It is shaped like a small teardrop or punching bag. Uvula, it is the part of soft palate. The soft palate is the muscular section of the roof of your mouth. A patient with the bifid uvula will have more trouble moving their soft palate during the times of eating, drinking and speaking. Food may not be digested properly and speech can be distorted. So this is especially true when the uvula is deeply split. Extreme nasal sounding speech may also indicate the presence of bifid uvula. This occurs because the soft palate does not properly move to the back of throat, allowing air to escape through the nose when talking. A bifid uvula is sometimes referred to as mildest form of cleft palate. The cleft palate is the one of the most common birth defect. A bifid uvula can also be a sign of underlying submucosal cleft palate. A 10-year-old boy presented with bilateral facial swelling along with the eyes raised to heaven appearance. What could be your diagnosis? The answer is cherubism. Cherubism is characterized by eye upturned to the heaven appearance. What you would see is there will be involvement of inferior and lateral orbital walls that tilt the eyeball upward and retract the lower eyelid. So it will expose the sclera below the iris that produces eyes upturned to heaven appearance. So this cherubism is a rare developmental jaw condition that can be inherited as autosomal dominant trait, and the gene that is associated with it is SH3BP2 gene. The name cherubism was applied to this condition because the facial appearance is similar as that of plump cheek little angle. So the plump cherub-like cheek results from the painless bilateral symmetrical expansion of the posterior mandible. In the mandible, the lesion frequently develops in the ascending rami and coronoid process. but the condyles usually are spared. Extensive jaw involvement causing marked widening and distortion of alveolar ridge. The lesion may cause tooth displacement, tooth mobility, failure of tooth eruption, impaired mastication, speech difficulty, upper airway obstruction, or vision or hearing loss. On radiograph, what you would see is typically it shows bilateral multilocular radiolucencies. Biochemical findings typically are normal in patients with cherubism. If laboratory results do not suggest hyperparathyroidism, then the children with bilateral symmetrical giant cells represents the example of cherubism. So on a microscope, what you would see is vascular fibrous tissue with variable number of multinucleated giant cells and scattered hemorrhage. So these giant cells tends to be small and aggregate focally. The cherubism reveals eosinophilic cuff-like deposits surrounding the small blood vessels. So this eosinophilic cuffing appears to be specific for the cherubism. A patient presented with complaint of multiple retained deciduous teeth. The clinical picture is suggestive of which of the following? The answer is cleidocranial dysplasia. In this picture, you can see is the dental. In this picture, you can see is the clavicular abnormality, suggesting cleidocranial dysplasia. Now, what is cleidocranial dysplasia? It is a generalized bone disorder caused by mutation in RUNX2 gene. Which gene? RUNX2 or CBFA1 gene. So this gene normally guides the osteoblastic differentiation, chondrocyte maturation, and bone formation. So what are the defects or the clinical features that you will be able to see in the cleidocranial dysplasia? The bone defects chiefly involve the clavicle and the skull. The clavicle in this picture represents these are hypoplastic bilaterally, or the clavicles are completely absent. The patient neck will appear long and shoulder are narrow with marked drooping. The clavicular abnormality that results in unusual hypermobility, and the patient can approximate their shoulder anteriorly. What are the other features associated with cleidocranial dysplasia? The additional features include short stature, enlarged skull, brachycephaly, pronounced frontal and parietal bossing, ocular hypertelorism. On the skull radiograph, you will see fontanelle that show delayed closure or remain open throughout the life. The patient often had a narrow high arch palate and there is increased prevalence of cleft palate. For the teeth part, you will see the teeth that are over retained deciduous teeth and delay or complete failure of permanent tooth eruption that are the characteristic feature. On radiograph, you will see presence of numerous unerupted permanent and supernumerary teeth that exhibit distorted crown and root shape. So on the panoramic radiograph, you would see is the multiple unerupted teeth. All of the below given factors are responsible for causing dental caries, except the answer is temperature. As we know that caries and oral mucosal and periodontal disease are the major cause of oral health problems. The dental caries etiology has primarily four main factors. What are those? It's the bacteria, time, susceptible tooth surface, and fermentable carbohydrates. Due to high prevalence of oral disease and increased microbial resistance against antibiotic, there might be need for alternative method. So caries, what is caries? It is a chronic multifactorial disease that causes destruction and demineralization of hard tissue of teeth by the acid formation occurring from the bacterial fermentation of foods. What is dental plaque? Dental plaque, it is a sticky substance that sticks to the surface of teeth. It is considered as a complex biofilm that is the main cause of dental caries. The dextran produced by the dietary sucrose fermentation by Streptococcus mutans. It is the main responsible. It is responsible for the stickiness of plaque. As a result of fermentation, what Streptococcus mutans would produce? They would produce lactic acid. So that ultimately starts enamel decalcification. So this plays an important role in initiation of enamel caries. So if the dental plaque is not removed properly, tooth decay would flourish. The four main factors that are associated with the dental caries are the bacteria, time, susceptible tooth surface, and fermentable carbohydrates. So it's time and not the temperature. So answer will be temperature. A patient presented with lesions as seen in the color image. Histopathological reveal suprabasilar split and presence of Zang cells. What is the diagnosis? So your diagnosis would be Pemfigures vulgaris. So what is Pemfigures vulgaris? Pemfigures vulgaris, it is a autoimmune intraepithelial blistering disease that will affect skin and the mucous membrane. What you will see here is circulating autoantibodies that are directed against the keratinocyte cell surfaces. So this blistering in this disease is due to abnormal production of autoantibodies that will direct against the epidermal cell surface glycoprotein desmoglein 1 and 3. So these desmoglein, they are the component of desmosomes. So what the autoantibodies will do, they will attach these desmosomal components and inhibit the molecular interaction. So as a result of this attack on the desmosomes, what you would see a split that develops within the epithelium. So this split is responsible for the blister formation. So the Pemphigus vulgaris involves the oral mucosa, typically in adults at age of 50 years. What you would see here is the patient will report with the bulla formation. So there will be vesicles and bulla. So these lesions will contain thin watery fluid shortly after development. So when the bulla, it will rupture, it will leave a raw surface. So a characteristic feature of Pemphigus vulgaris is that a bulla can be induced on normal appearing skin if a firm lateral pressure is applied, and this is positive Nikolsky's sign. On histopathic examination, what you would see is the superficial layer of epithelium, they are stripped away, leaving only the basal layer of cells that has been described as row of tombstone. The cells of spinous layer typically appear to fall apart and they are termed as acantholysis. That they term a round shape appearance, and these rounded cells are known as Zang cells. that can be seen in exfoliative cytological preparation. The diagnosis of pemphigus should be confirmed with which test? By the direct immunofluorescence test, by the Michel solution. So when with this procedure, antibody IgG or IgM and complement, usually C3, can be demonstrated in the intercellular space between the epithelial cells. We can use indirect immunofluorescence or ELISA can be used. What is the treatment? The treatment, it is a systemic disease. Therefore, treatment would primarily consist of systemic corticosteroids. Usually the prednisolone is given, or we can give immunosuppressive drugs or azithromycin. Which of these factors has not been assigned an essential role in Miller's chemico-parasitic theory of dental caries? Miller assigned essential role to carbohydrates, substrate, acids, and microorganisms in causing dental caries. Factors like heredity did not find mention in his theory. In fact, one of the objections to Miller hypothesis is inability to explain the site and racial prediction. So your answer will be C, that is hereditary.